Welcome back to Women Out Loud. We are on the couch today, back with the OG group. We've got Dr Niamh Logue. Hi, Niamh. We've got Courtney Weybury, physiotherapist.
Hello, Amy.
I'm Amy McElgunn, registered nurse, and we have a very special guest with us today. We have Kate van Berkel, a dietitian. Okay.
Hi.
Kate is Senior Diabetes Dietitian at Bowen Health and a private practising women's health dietitian working with us at Surf Coast Women's Health Group.
Great to be here.
Yeah, great to have you on board. So today's episode is about GLP-1s. And we know there's a lot of noise out there, so we thought we'd get into it and try and get through the basic understanding. Thought we'd start there. So, Niamh, if we start with you, GLP-1 medications have become a huge topic of conversation. With weight loss medication and all the talk flooding the media, can you start by clarifying what are GLP-1s and how do they work?
Sure. So GLP-1 medications they mimic the effect of a naturally produced hormone, which is produced in our small intestine, and that hormone is called GLP-1, which stands for glucagon-like peptide 1. So it's a fancy name for a hormone that we all produce in our small intestine after we've eaten.
Okay.
And the medications that have been licensed for diabetes and weight loss mimic the effect of that. Their full name is GLP-1 receptor agonists. So they mimic the effect of the normal hormone that's produced, and they enhance its effects. So in a nutshell, that's what they are. What they do in our body is they have quite a few effects. They regulate our hunger. Mm-hmm. They help to reduce our appetite. They help us feel full after eating. But also within us, they help to promote our insulin release after we've eaten. And insulin is a hormone that we produce naturally, which helps regulate our blood sugar. And the GLP-1 medications, they also stop a different hormone from being produced, which is glucagon. And glucagon helps to elevate our blood sugar. Mm-hmm. So in essence, what we feel when we take a GLP-1 is that it feels like an appetite suppressant. We're full, we're not hungry, we don't want to eat. But what's happening inside of us is that our blood sugar has been regulated through various different hormonal pathways.
Okay. Great explanation. Thanks. So then, Kate, what do you feel with our chat today, with all the complexities that are in there, what do you think we need to be addressing today in regards to GLP-1s?
So I think there is a lot to talk about with GLP-1. So there's this big, broad conversation in GLP-1 use from a population perspective. Mm-hmm. So when we're looking at influences around, body image and diet culture and positive benefits from a more public health perspective of some of these medications being used. And then we have our individual perspectives. Mm-hmm. So for those that have made that informed decision with their GP or their endocrinologist, what care do they need to thrive with these medications and to have the benefit that they need while minimising the risk?
And taking into consideration all of their really specific health needs.
Yeah. Very individual.
Yeah. Yep. Great. So then, Niamh, who are GLP-1 medications typically recommended for, and what needs to be considered before starting them? Because there's two parts to that.
Yeah, which is huge. And really, I think more discussion needs to be had about this because it seems to have gotten lost a little bit, as in, what are they licensed for?
That's it. That's a good question. So from a PBS, who are they licensed for in Australia?
So they're licensed for people with type 2 diabetes, and they've been used. The umbrella term of GLP-1 medications have been used for decades in people with type 2 diabetes. Okay. They have now since gotten a licensing for weight loss because we understand that obesity and extra fat, it makes it very, very difficult to control blood sugar and type 2 diabetes. So they're the two groups that they're licensed for.
And when we say license, do we mean that sort of you get it cheaper on the PBS?
No, it's nothing to do with cost.
Okay.
Licensing means that there is clinical trial data to prove that this stuff does what it's supposed to.
Yep.
And we understand the side effect profile really, really well. So we can give evidence-based advice on this stuff works for this, the side effects are this, and the risks are this.
Okay.
So that's what license means. PBS, that's a separate conversation.
Yep.
Because pharmaceutical companies have really hit a rich seam of gold with this stuff, and it's phenomenally lucrative for pharmaceutical companies.
Absolutely.
So that's a different conversation between governments and big pharma to decide what goes in the PBS. There are PBS listings for the GLP-1s for people who've had a heart attack and a stroke. Semaglutide, Ozempic actually is listed on the PBS. There are many loopholes to jump through.
Okay.
Same with type 2 diabetes. If someone has type 2 and they failed trials of oral medication to control their blood sugar, there is a PBS listing for semaglutide, which is one of the GLP-1s.
So then prescribing off license, which we know is something that happens for sort of other conditions or not meeting those requirements you said, that's something a GP can do, but that might not be best practice. If it's prescribed, it might be reasonable, but that's what we mean when we say just because it's not. A GP can actually still prescribe off license.
GP, and we prescribe lots of medications off license.
Yeah, okay.
So, there's, birth control, we prescribe it for heavy periods. And, this sort of thing. So prescribing off license is done, but there's no data. There's no data to confirm that that's best practice. It's done very much on, we think this is good.
Yeah.
Just going back to the question about who are GLP-1s used for. In weight loss, there's really specific criteria around that, and it works from a person's body mass index. So obesity, which is a tricky word because it brings up lots of negative connotations, but if we're talking factual terms here, obesity is defined as a body mass index greater than 30. Okay, so GLP-1s are licensed for weight loss in people who have a body mass index greater than 30, or people who have body mass index greater than 27 if they already have a medical condition, which means that they're at risk, and that would be blood pressure, so high blood pressure, high cholesterol, so-called pre-diabetes, insulin resistance, impaired fasting sugar, another thing, obstructive sleep apnea. So it's actually really simple when you look at the guidelines of who we should be prescribing for.
But haven't we moved away from BMI? Or that's just still part of the licensing?
I think, yes, we understand that BMI is an imperfect measure of health.
Waist measurements become, I know in nursing, we do focus much more now on someone's waist measurement rather than their BMI.
It is a very imperfect measurement of health. But this, I suppose from a GP perspective, sometimes there can be a bit of a mismatch between why do GPs think like this versus why do people think like this. And from a GP's perspective, these are the criteria we're supposed to meet. So it's not moved away from BMI.
Yeah, okay, fair enough.
It's not moved away from BMI at all.
And it doesn't mean that we have to prescribe them.
No.
It just means that the options on the table. And it doesn't mean that they always should be prescribed.
100%. Yeah. That's what the licensing
mean. Yep, fair enough. Can we discuss the difference between what people are hearing outside in the community on the media versus then the realities when it's individually based on them and they're in the room talking to you?
Let's talk about maybe the way that the medications are marketed or sold, which is from lucratively earning drug companies. That maybe the perception of anybody who's wanting to trial these medications might be that they are going to get all of the benefits that are reported. This average 15% weight loss for some medication, for some clinical trials, that they will continue with it forever. And that's not always the real life situation.
Because there's a very transactional nature with this stuff. There's a very consumerist thing. I'm paying $500 a month. I expect to be a size 8.
Yeah.
And I've had that anger directed at me.
Yeah.
Why isn't this happening?
Yeah. And I guess it's a really good example of where big funded clinical trials, so the majority of clinical trials that I've read are funded by the companies who are making the medication, which doesn't mean that they're necessarily bad trials, but we still want to check in on, you know, any potential bias within these giant studies. So we can hear averages from that. And we also, particularly for clinical trials versus observational trials, for clinical trials, any of those participants are getting the drug for free. They are having regular dietitian. You know, it might be once every 3 or 4 weeks. They'll have a free dietitian. They'll have exercise support as well. They've got clinical nurses who are checking up and providing any other symptom management.
And that's often missed because people who are just getting it off the internet aren't having any of that.
No.
And so they're not having the same outcomes.
No.
And so they're like, I thought you said I was going to lose 30% or 15% of my body weight. I'm like, well, you would if you were in that clinical trial.
Yeah. On average, yeah. And so within that, as you said, Niamh, there'll be people who might lose 2 kilograms, which is commonly, before we were using these medications for weight loss, when we're using them in that diabetes realm, we might see a couple of kilograms of weight loss. That was pretty common. So, yeah, some people might lose 40 kilograms. When we're talking in averages, that's not the median. That's not what most people get. It's the middle point between the no weight loss at all and the lots of weight loss. Yep. And I guess the other thing clinical trials will report, but aren't always reported, I guess, broadly in the media, is dropout rates as well. So when we think about these drugs being recommended forever in order to maintain weight loss, we don't have forever drug trials. We have 4 years. I think we've got some 7 years. By 7 years, the dropout rates are pretty high. So again, that's something that is really difficult to replicate in real life because we don't have all of those same barriers and supports around it. And we also don't have the forever data yet.
Yeah, so the information people are getting in the media and, you know, getting whiffs of the research and the data that's out there, you're not necessarily seeing, it's not always the same then with that individual patient in your clinical room.
Completely different.
Yeah, different.
And that's a lot for people to take on, isn't it? Because as a layperson, the information that's out there for us, you kind of hear all this noise and hear it all, and then you go into your GP room or your physio room or your dietitian room and then think, well, I want that. I want that. And it's not necessarily what people are getting. Interesting. Let's move on now to nutrition specifically and supporting. So I guess we're discussing people who are on GLP-1s now and saying, okay, so people who are on a GLP-1, how can we support their body's needs with the appetite changes that I guess can be expected? So Niamh, for you, when women come into the clinic after starting, or I guess maybe before, you talk me through that, but what are the biggest challenges or concerns they're sharing with you?
That they don't want to eat, that the appetite suppressant effect is too great.
Yeah, interesting.
And in a sort of a funny way, that to them demonstrates that it's working and that they are going to lose weight. So that side effect is almost celebrated. So the absence of hunger cues, the absence of, oh yeah, I need to eat now because I'm hungry, that is almost kind of celebrated a little bit. But actually that's often makes side effect worse, particularly nausea. So nausea is a really common side effect with GLP-1s. It's dose related, but if someone isn't eating because they're not hungry, I often see their nausea is worse. So a conversation that I have at the very, very start is we need to get a nutrition plan going so that if your side effects are interfering with this nutrition plan, I need to talk to you about amending the dose. So the nutrition plan has to come first.
Yeah, great.
Because like we said, they are appetite suppressants. We're expecting that to happen, but that cannot come at the expense of nutrition because our bodies need fuel. Our bodies need fuel.
Needs fuel.
And that's the basis for health. So, yeah.
So then, Kate, how do you, when you step in then and someone comes to see you and they've started a GLP-1, if they do have a suppressed appetite, how do you make sure their bodies are getting what they need?
And it can be really tricky. I think we also need to consider somebody's history with dieting prior to starting GLP-1. So if somebody has a long history of dieting or any disordered eating, then as Niamh said, that not eating and being able to go for vast amounts of time without eating isn't necessarily feeling like a bad thing. As a dietitian, it makes me very worried. So working with GPs in that reporting back of this person is unable to eat enough, I guess having that group discussion as a multidisciplinary team I think is really important. Realistically, if somebody can't eat 3 meals a day plus some snacks, there's a problem. And I think a lot of people on GLP-1s aren't doing that.
Yeah, I would agree.
And we're going to assume that big meals might be really uncomfortable, or normal sized meals, which is where that intermittent snacking becomes really important. But in the absence of hunger cues, it's really normal that we might want to eat every 3 hours. And I think if you have been taught that any hunger or want or keenness for food is bad, then wanting to eat every 3 hours might feel terrible. If anyone's got small children and they don't eat every 3 hours, we're not going to set ourselves up for failure in that situation. But I think with adults, particularly people with a history of dieting, we subject ourselves to these big amounts of time without eating, and it might feel really good at the time, but we know from research that we can see decreased cognition, decreased emotional regulation, decreased gut peristalsis, so movement through the gut, which can have implications for gut function and constipation risk. We would be working towards those 3 meals a day plus some snacks, and at what dose is that achievable?
Do you find, Niamh, obviously we've talked a lot about this in previous podcasts, things about the social pressures and how we all grew up and diet culture and how that impacts us all and our almond mums. And do you think women are still surprised by their nutritional needs? That you as a GP, that you're going to really kind of encourage that? And do you think there's still a lot to learn in that sense?
I do actually, because we were still influenced by diet culture. And the less is more in terms of calories intake per day, numbers on the scales. And I actually have had conversations with a lot of women who would say to me, I don't know how to eat. I don't know how to eat. Like, what am I supposed to be
Like, I don't know what my body needs,
And I think, and again, this happens in midlife when metabolism changes, weight gain happens around the middle. And women will come into me and say, I'm eating less than ever. And these fat cells are immortal. They are going nowhere. And I don't know what to do. Short of starving myself, I don't know what to do. So, that message of nutrition is a different concept to weight, either gain or loss. Nutrition is basic. These are the food groups that we need to eat in order to keep all of our body cells going. It's almost like we need to have that conversation again. Because that's not common knowledge.
Because we didn't learn it, did we, back?
Because less is less.
We learn it in health and human development.
Yeah.
But then there's a lot of uneducation that happens in the middle.
I don't think. Do you reckon you learned that like in the early noughties? Sorry, I'm exposing our age.
Yeah. I think that's when I decided to become a dietitian, actually. Yeah. Between that and biochemistry, I was in.
But if you didn't do that subject.
Correct.
Then we don't know this stuff.
And I think something as a dietitian that you find when you're meeting with people who are trying to lose weight for various reasons is that as a dietitian, our job is to get more nutrients in. And I think particularly earlier in my career, you felt like part of your job was to get people to eat less somehow. But that's not what we want to do as dietitians. That's not our job. Our job is to make sure that within what anybody is able to eat, that they are getting what they need to thrive, because we don't, we might be looking at GLP-1s for improvements in blood sugar management, but we also want to think about long-term cognition. We want to think about long-term bone health. There are just a million little metabolic processes happening in our body that need all these weird and wonderful little nutrients. So we don't have to think about all the time if we eat enough. But once we're starting to miss a lot of meals and, maybe having one meal a day, the risk to those little systems that normally run by themselves beautifully can start to be impacted on.
And it's tricky because that is not discussed a lot of the time with, especially in kind of doctor appointments. I've talked to plenty of patients in the past and the advice to them was, well, I was told to lose weight. And so immediately they think that means restriction.
Yeah.
And so telling people to lose weight without providing any guidance on, but here's how to maintain your health while doing that.
Yeah.
It's impossible.
Yeah. Physical and mental. Yeah. So then, Kate, from a nutrition focus, what would you say the main, I don't know, what do you call it? Is it a food group? What are people focusing on when they're on a GLP-1? What types of food do they really need to be prioritising?
So the word on the street is protein.
Yeah.
And
protein's PR is
Isn't it?
incredible,
protein,
isn't it?
I want their PR.
Yeah.
I think fibre might be using protein's PR.
Yeah.
Carbohydrates need their PR.
They do.
Absolutely.
Yep.
They're getting their PR team is terrible. So we talk a lot about protein, and protein is really important, and it's not the only thing that we need. So we can kind of use protein as a bit of a way to encourage increased eating because people feel really positive about eating more protein. So, but if you are eating, again, those 3 meals a day plus some snacks, without thinking too much, most people will be getting enough protein, even if they're portion sizes. So that meal regularity, so if you want to think about a priority, that eating regularity, working with the team, if you haven't eaten breakfast for 20 years, maybe your hunger cues are pretty quiet at that time of day.
Yep.
And maybe we can do a bit of fake it till you make it. And so start to practice eating at that time, and then the gut and the brain can start to expect eating at that time, and it just builds into your day. So regularity of eating is the most important nutrient
Great.
to focus on. We do want to consider protein, but we don't want to consider it we don't want to be living on high protein bars that are otherwise devoid of other nutrients in order to meet those protein goals. We want to, where we can, use food that contain multiple nutrients. So particularly, I guess, for women in midlife and onwards, when we're thinking about bone health, dairy or calcium fortified dairy foods, so they could be calcium fortified soy-based foods or calcium set tofus, aiming for protein for those foods where we also get calcium is a big win.
Okay.
And when we look at data from a food group perspective of people who are on GLP-1s, dairy-based foods or dairy alternatives are low across the board. Fruit is also really low. And I think if we stop snacking and we're trying not to, maybe we've tried to not have as much quote unquote sugar, maybe we're trying not to snack between meals, fruit drops right off. And we're actually seeing quite high vitamin C deficiency prevalence. We didn't used to worry about vitamin C, and then maybe we worried about it when we were sick, but actually fruit intake and vitamin C intake from a depression prevalence perspective, fruit is the one thing that sets apart, new onset of depression. So we do really want to consider that from a mental health perspective as well. We're all putting vitamin C serums on our face, but we can also eat some oranges or mandarins.
2 kiwis a day, Amy.
2 kiwis.
2 kiwis. Yep.
Neve's number one advice at the moment.
So if
Amy's not down with the 2 kiwis a day.
2 kiwis for bowel regularity, baby.
Yeah, but it's
so
like
good.
$4.
Yeah,
the skin on.
Depends on the season.
You gotta eat the furry skin.
I'm a skin on person too.
thanks.
Extra fibre.
All of you.
Skin on couch over here. Yeah.
Skin on, extra fibre. So I guess if we think, going back to whole foods, if we're thinking dairy alternatives, we get multiple things from that.
Yeah.
If we are thinking fruit, sounds really lame coming from a dietitian, but we're getting vitamin C, we're getting fibre to help, particularly with kiwi, to help maybe prevent some of those gut dysregulatory symptoms that can come, like constipation and bloating and discomfort. That's true. Am I allowed to pick any more?
You can have one more.
No, I've had regularity.
Yeah, you started with regularity.
Eating regularity. That's me.
That's great. All right, so how about we move on now to talk about strength training and protecting muscle during weight loss. So, Court, you've been sitting on the sidelines ready to pounce. This is your time.
Let me at 'em.
Yeah. So strength training. We hear a lot about strength training, but it's kind of a bit intimidating for a lot of women, especially if you've never done it, right? What does strength training look like for everyday women?
Yeah, great question. I think a lot of the time to start with, people instantly think a gym, so
Yeah.
As you said, it can be intimidating. There can be a place where a lot of people don't have a lot of confidence.
All the
much
gym
experience.
bros. Yeah.
But you don't have to go to a gym. You can do lots of strength stuff at home or at the park or at other places. But the main things are that with strength that you're using resistance, using weight. Just to help stimulate and stress the muscles and to build new muscle cells and develop strength. So as it's been touched on a bit already with the GLP-1s, as well as losing, like when you talk about losing weight, like what is it that's composing of that weight? So you have fat cells, but there's the water and there's also muscle. So, really making sure that, again, when we're focusing on health, that someone's not losing too much of their muscle mass. And then even that link then too with bone, for bone health, muscle strength and bone health, it's so important. So
Yeah, so that idea of determining your health on seeing the scales drop.
Yes.
But what have you cost yourself? Yeah.
Yep. And then even trying to flip things again, like focusing on, again, if you're focusing on health, while someone might be wanting to have a number as their goal of losing weight to be at this weight, I would say let's focus on how many squats you can do, or how much you could lift, or how quickly you could walk that distance. So just trying to rejig and reframe your goals of making them more health specific. And the other things are a bonus, but again, you're just really focusing on health.
And is that why seeing an expert, whether it's physio or EP or an excellent PT, would be good, because then you could help develop some baselines and then kind of stay on top of that?
Yep, definitely. And again, because each individual is different with what motivates them and what they might have access to financially or time-wise. There's so many barriers, I guess, in what stops people from exercising and staying strong. So working with an exercise physiologist or a physio or PT, as you just said, we can really tap into those things and work out what that person needs and what they can do. And the simpler and easier we can make it, then the more likely you are to do it.
Yeah, great. So then, Niamh, why does strength training become more important while someone's taking a GLP-1? Because my question is, if I'm on a GLP-1, am I losing muscle mass just because maybe I'm dropping a few kilos and I'm not eating much, and so I'm not really doing much exercise? Or am I losing muscle mass because of the medication in and of itself?
It's probably a combination of both.
Yeah.
It would be a combination of both. Is that the body will look for energy sources from wherever. And we know that, as Courtney said, the weight loss that comes from GLP-1s is a combination of water, muscle and fat. And really what we should be focusing on is fat loss. And that's not guaranteed with GLP-1s. It's indiscriminate weight loss. And that's the problem, because with some of the data that's been published on muscle mass loss in someone who's using it without support of dietetics, of physio, it can be up to 30% muscle loss.
Wow.
Which is devastating, because we know that most people will stop their GLP-1 within 12 months of starting it. We know that almost all of the weight that they've lost will go back on. And 100% of the weight that goes back on, that's fat. So no one's regaining muscle once they stop a GLP-1. They're regaining fat. So you've got a 30% muscle deficit and you've regained all that fat. And so that leaves someone's health in a much worse place than before they started it, which is devastating. Like this is not what we're aiming for at all. And that's the big risk with this concept of weight loss for weight loss sake. That really can't be the discussion that we're having. And that's why sometimes we can be a bit conservative when prescribing this stuff, because these medications have revolutionized healthcare. I'm so glad we have them and they're so beneficial. But if a person is given this drug without support education, their health can actually worsen, and that would be a disaster.
Great. So then, from a strength training instruction point of view, how much is enough to help maintain muscle while losing weight? You know, what do women need? What would you prescribe from an amount? How many times a week? What do we need to be doing?
A lot of evidence and research shows that doing 2 sessions of strength a week is enough.
Yep.
So it doesn't have to be something you do every single day, but I always say to people, aim for 2. If you get 3, bonus. Aiming for 2 sessions a week. And then I guess it depends again then what that person is doing for their strength. If it's lifting particularly heavy, then sometimes you don't need to do it as long. So, you know, all those sort of things can influence it. But twice a week, which is pretty doable.
Pretty doable. And it's cool that if you could get that individual program with someone where they could literally say, this is my lifestyle, this is where I could fit things in. I've only got time for this or I've only got time for that. That then you could kind of make a specific plan for that person.
And sometimes it's even trying to sneak little things into their day. Rather than trying to find half an hour, you know, to try and do it. Like, that's great. But, you know, the more incidental things you can do throughout the day as well helps too. So,
Great. Kate, can someone still lose weight successfully if they're not exercising, or are they missing an important piece of the puzzle?
I guess that depends on what we mean by successfully.
Yes.
If successfully is making numbers on scales and body size go down, yes, with these medications we see that. But if success means safely and I guess recognising all of the other things that exercise. I mean, exercise as a way to lose weight, you know, the evidence is fairly mixed. Evidence for health, the evidence is extremely strong. So if we're looking at longevity, if we're looking at non-Alzheimer's dementia reduction, if we're looking at cardiovascular risk, if we're looking at blood sugar management, if we're looking at mood, vitamin D status, we can't do that without exercise. It's the thing that we can't give a drug for, that we well, and also nutrition. The 2 things that we have to do. And you don't just get one benefit out of them, you get multiple benefits out of them. I don't think we've had any studies that show that if you don't exercise that everything will be fine.
I think, and again, just to chip into that, these medications shouldn't be prescribed unless and until someone is established on a nutrition and exercise plan. So
that would be best practice.
That should be the go. Like these are a tool in addition when our metabolism isn't playing the game, when our blood sugar's staying high and our cells are insulin resistant, despite adequate exercise and a good nutrition, that's where GLP-1s come in. So they absolutely should not be prescribed unless and until someone is doing that. And it's not a kind of, it's not to withhold a medication from someone who could benefit from it, but it's to emphasize the fact that the foundation of health belongs with nutrition and exercise.
And I think this conversation, it's so helpful, because I think that idea that someone might come into the consulting room and just really want you to prescribe that. But now kind of understanding why, because I might go and lose weight, but I've lost, you know, conditioning that I didn't want to lose. Like that's
informed.
That's a lot of knowledge that people need to have.
And other times people say to me, well, why is muscle mass important? Like, what are we doing with this? Why? I don't want to look like a bodybuilder. Like, I don't care if I'm muscly. What's the go? And it's that conversation about muscle burns more calories than fat. So the more muscle you have, the more effective the GLP-1s are.
Interesting.
So that's useful. And also because with our bone health, our bones need muscle. Our bones need force going through them. So our you know, and you know much more about this than me, but for balance, for avoiding frailty, if you know, not ending up in a nursing home, independent living, we have to maintain our muscle mass.
And then doing what you said, Court, doing, you know, a couple of strength sessions a week. Like, we're not going to get bulky and ripped, are we? You know, that kind of misconception that women are kind of, it's like, oh, I don't want to be, I mean, some people do, but for women who think, oh, I don't want to be huge, that's not.
It's not what we're talking about.
No. And that's not going to happen just with a couple of sessions a week.
Be nice if it was that easy.
Wouldn't it? That's
great.
Exactly.
Bodybuilder on twice a week
Done.
sessions, great, easy.
So then, Court, what would you say is one simple change women could make, this week to start building strength?
Ooh, good question. This week, if it's something just themselves at home without, reaching out to, I guess, professionals for that advice, my go-to easy thing that anyone can do is even just things like a sit to stand.
Yep.
Try and do 3 lots of 10 sit to stands out of your chair each day.
Yep.
So build up some strength in your quads and your glutes and your legs. Everyone has
Maybe
a chair.
test yourself on a few things, see what you can do. Yep.
But then, of course, that next level is, wanting more advice, reach out to your physio or your exercise physiologist or a PT. There's brilliant people out there that can provide a lot of really fabulous, easy advice.
And is that something, if I just
get strong or stay strong?
If I booked a physio appointment online, do I have to say it's going to be strength? Or if I walked into your room and was like, oh, I'm here, I'm actually really well, but I want to get stronger.
Yeah, I love you.
Okay, yes.
Proactive patients and people that come in like that are gold.
Great, okay. So now let's talk about long-term health. So Niamh, if we start with you, we hear the phrase quick fix, but from a GP's perspective, where do GLP-1 meds fit into long-term health?
So GLP-1s should only be prescribed for long-term health.
Okay.
They're in my mind, when I'm prescribing them, they fit into the same category as if I was starting someone on a blood pressure drug or a cholesterol drug or a diabetes drug. They are within that group. They are not a short-term medication. They should not be prescribed short-term. No, they are very much a tool in the toolbox to reduce someone's risk of developing cardiovascular disease in the future. So that's what we're aiming for. We're aiming for long-term health. And that's the conversation I have.
So then following on from that, if we know cost can become a barrier, how do you navigate the conversations around affordability, to ensure patients this is something they can do long term?
Point, actually, at the moment, because at the moment, like we said earlier, the PBS listing is only for patients who have established risk factors, established disease, so either type 2 diabetes, previous heart attack, previous stroke. So therefore, we're not able to use these medications for prevention just yet with the PBS. Yep. So in a sense, unfortunately, the GLP-1s are widening the health inequalities. These drugs are hundreds of dollars per month, and I have that chat straight up because the person needs to be able to afford them, unfortunately. And it is a financial commitment as well as a personal commitment to this medication. So unfortunately, we are in the situation of treating people who can afford it and waiting for people who can't afford it to get the disease until we can prescribe it with a PBS listing, which is not the sign of an advanced nation, unfortunately.
Yeah, the equity.
The equity's horrible. There is, it's very inequitable at the moment.
And it's not just the medications, also if you want to see a dietitian and your physio and all of the stuff around it.
Being healthy
clinical
costs
trials
money.
provide.
Being healthy costs money, and the GLP-1s, while they are life-changing, and I'm so glad we have them, they are reinforcing the inequity currently as it stands. And I'm not criticising Australia for that. This is happening, in all over the world. They're reinforcing the inequity because the trials cost millions and the drug company set the price.
That's it. And someone's making money. So Courtney, beyond exercise, in terms of long-term health, what healthy habits make the biggest difference in women maintaining, I guess, their results or maintaining good health?
I think just being regular, just trying to keep up with things, like making them a regular habit, putting yourself first sometimes, again, to that framing it, that putting your health first. So, of course, we can have so much going on in our day that it can be so hard to find half an hour, but just even framing it that, in your 24-hour period, in your 24-hour day, you need to find 30 minutes to do something for you, to go for a walk or, even those little things like parking a little bit further away and walking that bit further, just, all those little incidental bits of exercise that can help, but just, trying to keep things regular.
Yeah, great. And then, Kate, if someone does come off a GLP-1 how can they set themselves up for long-term success, good health, rather feeling, that sort of bouncing back and forth, feeling like they're starting all over again?
Yeah, great question. And like Niamh said, the amount of time that people are actually on these medications, depending on the study, some are 5 months, some are a year, some are 2 years, cost. I don't envy people having to make the decision to stop medication if it's because of their gut symptoms or because of cost. I think that is really hard. We don't have any good evidence to say that they won't regain the weight, and that can feel really daunting, particularly if someone has, received a lot of positive feedback, whether from the healthcare system or from their loved ones, about how good they're looking or how good their health markers are doing. And then they think, I can't afford to keep this up. I'm going to come off it. That happens. We see that in clinic. So I guess what I would want to be proactive about is, while somebody was still on the medication, can we start practicing some of those intuitive eating? Can we start to, particularly if there's any dose reduction or wean off, can we start looking for those hunger cues, working with them, practice that regular eating? We know that food noise, the number one thing that pushes food noise, which people enjoy not having while they're on these medications, is restriction. So if we can get into that regularity, if the brain is not having to constantly push the person to find more food because they're eating multiple meals a day and some snacks and not having big gaps of time, that can be really helpful from a food noise perspective, but also a preventing. We know that if we're eating more regularly, we're less likely to then, at the end of the day, have our head in the cupboard and eating foods unintentionally or unmindfully. Building those habits, and if body image is being tricky, let's get some support for that. That might be through psychology.
Yep, great.
Particularly if it's been hard before coming onto the GLP-1, and if that was a guiding reason of why somebody wanted to start. That doesn't have to be a permanent state. There are tools and strategies. There is help out there to support your body image. So that if your weight does come back on, it's not going to feel as catastrophic as it might have without those tools.
Yeah, great. Okay, so to wrap things up from the three of you, Niamh, if we start with you, if there's a takeaway message, and one thing that the way people in Australia talk about weight loss and GLP-1 medications, what would you want to see change in that conversation?
I think I'd want people to be very clear about why they think they need to lose weight. Where has that message come from? And where was the evidence that that message was given? So that why does that person think they need to lose weight? Why are they thinking about going on a GLP-1? And to really analyse that thought first within themselves and with their GP. Why? Think about what's driving that. And then I think it splits into, is this for health or is this to feed into diet culture and body image? They're two totally different roads, and GLP-1s should not be used to feed into body image and diet culture at all. And that's where, unfortunately, I think a lot of people are getting sucked into. If it's because they've been given medical advice that their weight, BMI, even very imperfect number or very imperfect measurement, but that their BMI is going to be to their detriment in the future, yes, different conversation. GLP-1s are a tool, but nothing replaces diet and exercise.
Court, what would your take-home message be about getting advice and support for women either looking to navigate this or already being on the GLP-1 journey?
Yeah, I think don't do it alone. Seek help and get that support from people the team we've got here, from having your GP and an exercise person and a dietitian. Gather the info and the facts, and don't do it alone. Don't be. I think some people are ashamed of it too. I've heard a few people that have whispered that they're on it.
Yeah.
Do what you can to help it, and to, as Niamh said, it's a tool. So use all the other tools you can to get yourself as healthy and strong again, going back to strength as you can.
Great.
Don't do it alone.
Great. And Kate, finally, what gives you hope when you look at where this conversation around women's health and weight management is going? Do you have hope?
Do I have hope?
Let's start there.
Maybe I have hope for GLP-1s in the same way that I have hope for AI. Bear with me for my analogy. That there are some amazing applications and there are some aspects of it. You know, I know that we use AI in clinic and it's can be so helpful, so targeted. And also there's a part of me that just wants to say, just hang on a second. Yeah. Maybe we need to have a think about how we're doing this first before we dive right in without having a think about the broader picture. Yeah. So that's maybe a little bit pessimistic of me. Look, I think it's hopeful for people who are requiring GLP-1s, which again, people who've been using these medications at a lower dose for a long time. But for people who are requiring GLP-1s at that higher dose, if it encourages them to eat really regularly, to allow themselves to eat really regularly, if it encourages them to focus on the quality of their diet rather than, I guess, just eating what is in front of them, actually considering what they might need for longevity and for the rest of their lives, that's kind of cool. If it is the first time they engage with resistance exercise, that's kind of cool. We're going to get net benefit out of that. So, yeah, I think that's where my hope is. If people are offered the help, and as Niamh said, ideally before they start on the medication so that they can practice those strategies and make sure that they can get them down before starting on the medication, then they'll have net benefit in other areas of their health.
Great. I think that'll do. Great chat. Thanks, everybody.